Good evening, everyone, and welcome to this ONS webinar. Tonight, I'm going to be talking to you about our young throwers, in particular our young baseball players and softball players. Thankfully, baseball and softball are back in action. The Little League has resumed, and our athletes are taking the field. And I thought it was a good time to talk a little bit about the injuries that these young throwing athletes often encounter, as well as touch on some of the risk factors that lead to these injuries. And finally, we're going to spend a significant amount of time at the end discussing the most important topic, which is preventive strategies that we can put into place to make sure that these athletes don't get injured in the first place. And at the end, we'll take time for questions as well. 30 million children participate in organized sports across this country. And what we are finding year after year is that young athletes are specializing in a given sport at an earlier age and specializing in a specific position within that sport at an early age as well. And this can be a problem, as we'll talk about later. 3.5 million children under the age of 14 are treated annually for sports injuries. And when we look at the type of injuries they sustain, about half of all sports injuries, at least in our middle schoolers and our high schoolers, tend to be the overuse injuries. And these overuse injuries are by definition preventable, which is really what we want to try to do. In regards to shoulder and elbow injuries among youth baseball players, we've found a 5 to 7-fold increase in these shoulder and elbow injuries since the year 2000. And about a third of 9 to 12-year-olds will sustain an injury to their upper extremity each year, and at least half of our teenagers will succumb to a shoulder and elbow injury at some point during their season. So it becomes an incredibly frequent phenomenon that we encounter as orthopedic surgeons in the office. Well, the problem can sometimes take root in the people that are responsible for taking care of these athletes, whether it be us as parents or our coaches and trainers. There was an interesting survey study that was done of all caregivers of young throwing athletes, and what the study found was that more than half of caregivers are completely unaware of safe pitching guidelines. And more than half of these caregivers do not actively participate in monitoring pitch counts, which is one of the easiest strategies to implement to avoid injury. 1 in every 5 caregivers is unaware of the number of pitches that an athlete throws in a typical game, and about 15% of caregivers were unaware of the type of pitches thrown. Now, you can look at this as a problem, but you can also view it as an opportunity. If we take these chances to educate our parents, coaches, and trainers about these issues, we can take significant steps towards preventing injuries in this vulnerable patient population. Now, an overhead athlete isn't only a baseball player or a softball player. The category of overhead athletes includes a wide spectrum of sports. In truth, volleyball, swimming, and tennis are all themselves considered overhead sports. Lacrosse and football, in certain respects, also includes repetitive overhead activity, particularly with regard to the quarterback, for example. But the archetype of the overhead athlete and the topic of this conversation is the baseball or softball player and the baseball pitcher in particular. So that's going to be the topic of the majority of this talk. But first, a few words about risk factors. There are a variety of aspects of these young throwing athletes that increase their risk of an injury. The first and foremost is the fact that these athletes are skeletally immature. They're still growing. And when you look at their bony anatomy, they have these open growth plates. These open growth plates are the location where the bone is getting longer and wider and stronger. But these growth plates are made out of cartilage. And because of this, the growth plate is the weak link in the chain. And when subjected to overuse, particularly in the context of repetitive throwing, these growth plates can be injured. The second most important risk factor for injury is improper technique. We'll talk in a moment about how technical the throwing motion is. And if the technique is improper or if the mechanics are abnormal or not properly executed, that athlete is at increased risk of injury. Now, specialization is the elephant in the room. As I mentioned, our young athletes are specializing in a given sport and a given position at an earlier age, and the lack of diversification increases the risk of an injury in these athletes. It's no longer anecdotal. This notion is now validated across the entire body of research. Rest is also exceedingly important to prevent injury and a significant risk factor for injury. If we don't allow adequate rest between episodes of participation, whether it be practice or competition, and certainly if we don't allow adequate rest after an injury, these athletes are at a significant risk for recurrent injury in the future. And now a word about the throwing motion. The throwing motion in baseball is one of the most technically complex skills across all sports. And it's undergone sort of an evolution in how we understand the various phases of the throwing motion. But we've broken it down into these 6 phases. It begins with wind-up, and then it moves through early and late cocking, and then through acceleration and deceleration, and finally culminating in the follow-through. What we find when we look at our young Little Leaguers is that these young athletes, particularly from ages 9 to 13, execute the throwing motion less well than their older counterparts. In general, their hip and trunk rotation is slower, and that can be a problem since we know that throwers generate velocity from their lower extremities and from their core. Shoulder rotation is also slower, and as a result, you get less synchronization between the arm and the rest of the body, and this is ultimately what leads to injury. These athletes can't develop the velocity and power from their core, so they try to compensate by developing all of their velocity from the arm, and the shoulder and elbow eventually break down. There's 2 critical instances in the throwing motion that are uniquely important when it comes to injury. The first is the late cocking phase. And the late cocking phase begins with lead foot contact and culminates in maximum external rotation of the shoulder. And there is a significant amount of torsional stress on the shoulder and the elbow, exceeding 60 Newton meters, and a significant amount of shear force on the shoulder, exceeding 300 newtons. As a result of all this, the shoulder and elbow can be injured in this instant, and it's quite common for athletes to describe pain during the late cocking phase. Deceleration is the second critical instant. This phase begins with ball release and culminates in maximum internal rotation of the shoulder. During this phase, the thrower is trying to get rid of all of the energy that they've accumulated during the preceding phases of the throw. There's a significant amount of compression force across the shoulder during this phase due to the significant contraction of all of the muscles to keep stability of the ball and socket joint at the shoulder. And as a result, again, a significant amount of injury occurs during the deceleration phase of throwing. And now on to a discussion of some of these injuries that we frequently encounter. Now, before I talk about shoulder injuries tonight, and before I talk about them with patients and parents in the examining room, I spend a decent amount of time talking to them about their shoulder blade and about their total shoulder motion. Both of these are important risk factors when it comes to the development of a shoulder injury in a thrower. If you remove the shirt of an injured thrower and you look at them from the back and compare their shoulder blade side to side with the other shoulder blade, you'll notice a difference in the posture, where the shoulder blade is positioned in space. And then when you ask them to move their arm in space, you'll notice a difference in the way the shoulder blade moves as compared to the other side. This phenomenon can be called sick scapula. The other medical term for it is scapular dyskinesis, or abnormal shoulder blade motion. And this phenomenon is a bit of a vicious cycle. When somebody has abnormal shoulder blade mechanics, it can lead to shoulder injury. And when somebody develops a shoulder injury, it can then feed back and affect shoulder blade mechanics. And so it's extremely important to recognize this as a risk factor and then address this through rehab in order to allow patients to recover from their injury. Total arc of motion is also incredibly important. Now, it's normal for a thrower to shift their total arc of motion towards external rotation. They have to be able to externally rotate more than normal in order to generate force and velocity during the cocking phase of throwing. So they shift their external rotation and they lose a little bit of internal rotation, but their total arc is preserved. That's normal. In contrast, internal rotation deficit, also called GIRD, G-I-R-D, is not normal. In this situation, they do gain external rotation, as I've mentioned, but they lose more internal rotation than they've gained in internal rotation. As a result, their total arc of motion is diminished. And this loss of total arc of motion, this loss of internal rotation, can increase their risk of injury. If they've lost 25 degrees of motion, if they've lost that amount of internal rotation compared to the other side, they're at a significant risk of shoulder or elbow injury for that matter. And again, when I examine these athletes, quite commonly, I'll see either one or both of these phenomena in the examining room. I'll see an abnormal shoulder blade mechanics, and I'll see a loss of internal rotation. And again, it's incredibly important to identify these and address them during rehab. Now, the most common shoulder condition to occur in our young throwers is a condition we simply call little leaguer's shoulder. And this is an injury to the growth plate of the humerus. We have a growth plate just below the ball and socket joint. And when you subject these athletes to repeated throwing, they will develop a stress reaction at the growth plate, and this can be painful. The average age of a patient with little leaguer shoulder is about age 14. These patients will complain of pain that's gradual or insidious in onset. When we get x-rays of these patients, the x-rays can be normal in mild cases. In more severe cases that perhaps were ignored, where the athlete was trying to play through it, we might even see a little bit of widening of the growth plate, as seen in this bottom panel, or fragmentation of the bone adjacent to the growth plate. Thankfully, this condition does very well. It has a favorable prognosis. It simply requires rest, some anti-inflammatory medication, some icing, and again, addressing the underlying risk factors. And they invariably return to their previous level of sport. If it's more mild case, they can return relatively quickly. But in more severe cases where there was widening of the growth plate, it can take up to 3 months to fully recover. Now, most athletes and parents come in to speak about the labrum. They assume that if there's shoulder pain, there must be a labrum tear there. The truth of the matter is labrum tears are rare in our youngest throwers and more frequently occur in our older athletes. The labrum is the soft tissue bumper, the cartilaginous bumper that runs around the edge of the socket. And the slap tear occurs in the upper portion from 10 o'clock to 2 o'clock on the clock face. The reason why this region of the labrum is important is that it serves as the attachment of the biceps tendon. The biceps tendon penetrates the joint and then attaches to the slap region. And this area can be torn in older throwers. There's a variety of mechanisms that have been proposed. It either can become pinched between two bony surfaces when you're in that late cocking phase, or the biceps can pull on the labrum during the deceleration or follow-through phase. If we're suspicious about a slap tear, we often diagnose it with an MRI, where we inject contrast into the joint to increase accuracy of the study. And what I try to reassure patients about if they're fearful of a labrum tear is that thankfully most of these labrum tears can be managed conservatively with rest, icing and anti-inflammatory medications, and again, rehabilitation to address underlying risk factors. It's only the rare slap tear that is either significant on MRI or the one that doesn't get better with conservative management that might require surgical intervention in our older athlete. Now, when we talk about elbow injuries, we try to conceptualize the elbow as two different compartments. We have the inner compartment and the outer compartment. And if you look at this athlete, a thrower in the cocking phase of throwing, you can see that the inner part of the elbow is subjected to tension, and the outer part of the elbow is subjected to compression. And that can allow us to understand the type of injuries that our athletes sustain during the throw. As I've said, the outer part of the elbow is subjected to compression. So we would expect that on the outer part of the elbow, we tend to see problems with the joint surface cartilage. And there's two types of conditions that can cause problems on the outer part of the elbow. They're similar in certain ways and different in others. One is called Panner disease and one is called osteochondritis dissecans. They both involve the capitellum, which is the area indicated by the arrows, the outer rounded part of the end of the humerus. They both are a result of repetitive stress in a skeletally immature patient and a part of the bone that may not have great blood flow. They both can cause pain on the outer part of the elbow and stiffness or loss of motion, although OCD can also sometimes cause clicking or catching in the joint, mechanical symptoms. But the similarities end there. There are some key differences. For one thing, Panner disease tends to affect younger patients, 10 years or younger, whereas OCD tends to affect our younger adolescents. When you look at x-rays, the Panner disease will cause fairly dramatic fragmentation of a large part of the capitellum, whereas the OCD lesion tends to cause cratering in a very small focal portion of the capitellum. MRI is not useful for Panner disease, whereas with OCD, it can help to evaluate the joint surface cartilage to see if there's already been fragmentation there. And the prognosis is different. With Panner disease, the prognosis is almost universally positive. These patients will do very well with a simple approach, including rest and rehabilitation. With OCD, it's a little bit more complicated, and it really depends on when the condition is recognized. If the condition is recognized in our younger patients, or when the lesion is so-called stable or still attached with intact cartilage, the patient can do quite well. If it's evaluated and recognized later, where the patient may have already reached skeletal maturity and their growth plates are closed, or if the joint surface has already fragmented and generated loose bodies, then the outcome can be less predictable, and some of these patients may require surgery. Now, on the inner part of the elbow, we talked about how the inner part of the elbow is subjected to tension. So we expect tension type injury either to the growth plate there or the ligament in that location. Injury to the growth plate of the elbow is similar to injury of the growth plate of the shoulder. Instead of being called Little Leaguer's shoulder, it's called Little Leaguer's elbow, and it affects the medial epicondylar growth plate indicated by the arrow in the top panel. And the mechanism is the same. It's repetitive traction injury to the weak link in the chain. And these athletes will describe pain during throwing. They may have some swelling in the area, and they may be tender on the inner part of the elbow. And again, in minor cases, the x-ray will be normal. In more significant cases, you'll start to see widening of the growth plate. So it's important to recognize it early, and if you do so, recovery is fairly straightforward. Some rest, occasionally some immobilization, and the athletes should be able to return to their previous level of sport. If the injury is more severe, where you've already seen some widening of the growth plate, recovery can take a bit longer. But much like slap tears in the shoulder, many patients and parents come in to see us concerned about the ulnar collateral ligament, or the so-called Tommy John ligament. And thankfully, this injury is rare among our youngest throwers, although we have seen that it has been increasing in frequency somewhat for a variety of reasons. The way these patients present will depend on whether it's acute or chronic. Our acute injuries are fairly dramatic. There's often a pop followed by swelling, some bruising, and pain on the inner part of the elbow. Chronic cases, on the other hand, are more gradual or insidious in onset. Patients will often have difficulty throwing. They may lose their velocity and accuracy, and they may simply be unable to throw altogether. And if the adjacent funny bone nerve or ulnar nerve is affected, they may also complain of numbness and tingling of their ring and small fingers. X-rays are rarely helpful for UCL injury, but can be helpful to rule out the other conditions we've talked about. And an MRI is often helpful. If we have a high suspicion, we'll order an MRI with contrast to identify a true tear and to help determine whether it's a full tear or a partial tear, which is much more common. Thankfully for UCL injuries in our young patients, treatment, the standard of care, is conservative. We are usually able to treat these athletes conservatively and get them back to sports. This includes rest, icing, and anti-inflammatories to control inflammation. We sometimes use bracing, depending on the severity of the injury. Our therapists will spend a lot of time focusing on core and hip strengthening and lower extremity strengthening, because a lot of times these athletes injure themselves trying to generate velocity from the arm alone, which simply doesn't work. Motion deficits are addressed because you've got to have full motion to avoid recurrences, and most importantly, before they go back to practice and competition, correcting abnormal pitching mechanics. There's a small group of kids who will simply be unable to return to their position, and they may not be a candidate for surgery. And for these kids, we sometimes will counsel them and their parents about a position change. And there's a small group of kids also who may in fact be a candidate for surgery. They may not get better with conservative management, so we may consider operative intervention. If it's a tear in a very young patient where it is truly pulled off of the bone, repair can be appropriate. However, the standard of care for most tears, especially mid-substance or chronic tears, tends to be reconstruction. Rehabilitation from a reconstruction can be prolonged. So if a repair is indicated, it can trim down the time to recovery somewhat. But we want to avoid taking these kids to the OR altogether. Prevention is really the holy grail. And if we return to the problem briefly, we have seen that over a period of 5 years in certain studies, there has been a 50% increase in the rate of elbow injuries in our high school athletes. And when you look at UCL reconstruction, or Tommy John reconstruction in particular, there was an increase from about 5 a year in the late 1990s to about 50 a year in the 2000s. So a fairly significant increase in the rate of surgery for these kids. When we look across the US, we see a 10% increase year by year from 2007 to 2011 of Tommy John surgery in this patient population. And when we look at the decade from 2002 to 2011 in New York State alone, an increase of almost 200%. So we want to try to do everything we can to keep these kids on the field and out of the operating room. And these are various ways we can do that. And it really all begins with strengthening and conditioning. There are a wide array of benefits to strengthening and conditioning, even in our youngest patients. For our non-athletes, it helps to maintain physical activity and increases bone mineral density and contributes to psychosocial well-being. But for our competitive athletes, the kids we're talking about in this presentation, it improves coordination and motor performance. It contributes to endurance among our youth athletes. And most importantly, and it's supported by the research, it decreases the risk of sports-related injury, particularly the overuse variety. But some parents still have concern about subjecting their young children to a strengthening program for a variety of reasons. There's a few myths to dispel here. First, is strength training unsafe for children? And the truth is, the risk associated with strength training is not any greater than any other sport that we allow them to participate in. Secondly, will strength training stunt the growth of my child? There's no current evidence to suggest that a supervised strength training program will negatively impact growth and maturation in these kids. Thirdly, what if my child experiences bone growth plate damage as a result of strengthening? And the truth is, a true growth plate fracture has not been reported in the setting of research with a competently supervised and appropriately designed strengthening program. Finally, children can't maintain strength increases because they don't have enough testosterone. And that's not entirely true. Testosterone is not essential for achieving strength gains. It is true that our post-pubescent or adolescent children have an easier time establishing and maintaining strength gains, but our younger athletes can certainly benefit as well. As a result of all of the evidence that has accrued regarding the safety of strength and conditioning, all of the professional societies have agreed in their consensus statements that this is safe even in our youngest patients. This includes the AOSSM, which is our Surgical Sports Medicine Society, the ACSM, which is the Primary Care Sports Medicine Society, and the National Strength and Conditioning Association. But there are certain pearls that we have to incorporate in order to make sure that it is in fact safe. So it should be supervised by a qualified and experienced professional, number one. Number two, it should be designed appropriate to the level of experience of our young athlete. And it should progress sensibly from one level of experience to the next. The equipment should be carefully selected. And the truth is, our young athletes can benefit greatly from a program that relies only on TheraBands or even body weight exercise. You want to limit heavy lifts and maximum repetition workouts at all costs. It's really not appropriate in our young athletes. And finally, just like playing sports itself, You want to allow adequate recovery time between sessions and to allow their bodies to recover and to avoid injury. One of the simplest and most straightforward exercise programs, particularly the throwers, is something called the Throwers 10. Now, this was developed primarily to rehab an already injured thrower or an injured thrower who's recovering from surgery, but it can also be incorporated as a maintenance program. And it basically includes some simple strengthening exercises, either with lightweight or therabands, that exercise the entire kinetic chain of the upper extremity, including the muscles that surround the shoulder blade, the deltoid and the rotator cuff, the biceps and the triceps, and the muscles of the distal upper extremity, including the wrist flexors and extensors. So a very simple program that you can get from the internet that can be very beneficial even to an athlete who's never had an injury who participates in a throwing sport. Now, game management is also exceedingly important, and thankfully, Little League Baseball has established a ton of guidelines that can be helpful to coaches and parents. The most easily implemented and the most widely discussed are pitch counts. Now, these pitch counts are based on age, and it tends to stipulate first and foremost the number of pitches per game, but it also stipulates the number of days rest and restricts tournament play. You can see that for our youngest thrower from age 7 to 8, they should only be throwing 50 pitches per day, no matter how many teams they play on. And as you progress to the 17, 18-year-old limit, that increases to 105 pitches. And the number of rest days required is dependent not only on age, but also the number of pitches pitched that day. So if you're a 16-year-old who threw 70 pitches, according to Little League guidelines, you then require 3 days rest before your next start. So these are very simple and easily implemented guidelines to manage each game of a young thrower to make sure they don't exceed the tolerance of their young body and of their growth plates. Pitch type is also important, although admittedly this is a bit more controversial than pitch count. Little League has provided some general guidelines, and there is some other expert opinion that has been offered based on basic science. The theory with these guidelines that I provide here is that you want to introduce pitches at an age when the athlete can easily master the technique. It's not only about how easily you can get injured, it's about how well you can perform the pitch. And that's why fastball is typically the first to be introduced. If you throw a fastball hard enough, you can certainly injure your shoulder or elbow. But in theory, fastball is the easiest to master, so it can be introduced as young as 8 years old. In contrast, sliders and splitters may be much more complex, and therefore are more easily done improperly, and for that reason shouldn't really be introduced before age 14. And these other pitches can be incorporated as stipulated in this graph. Now, considering the schedule of an athlete, not just on a given team, but during each season and across the year, is something called periodization. And it's important to take a step back and look at the 30,000-foot view, because these injuries are, by definition, overuse injuries, and it's not necessarily one moment in time. It's accrued trauma over the course of a season or over the course of a year that can culminate in an injury. So here are some concepts regarding periodization. Of course, you want to observe pitch counts and rest periods, as I've already mentioned. If possible, you want to avoid overhead throwing for 2 to 3 months a year, so that season is a great time to participate in a different sport that will have crossover benefit. You want to avoid competition for a season if you can, 4 months out of the year, even if you're practicing and training on your own. Avoid pitching more than 100 innings over the course of a year. Avoid pitching for multiple overlapping teams. Avoid pitcher-catcher combinations in overlapping teams, because this also has a significant amount of throwing involved. Encourage diversification, or participating in more than one sport over the course of a season, over the course of a year, because this crossover benefit will significantly impact the athlete's risk for injury. It will also incidentally make them a better baseball player, and this has been shown across the entire body of research. Finally, avoid radar guns at all costs and avoid showcases, particularly in our younger athletes. And then for parents, there's some clear guidelines to recognize injury. If we can recognize the injury early enough, as we talked about with Little Leaguer's shoulder and Little Leaguer's elbow, we are more able to recover them well and recover them quickly. So watch and respond to signs of fatigue, number one, that can be the first sign of an injury, and discontinue pitching if they're symptomatic. And it's not always going to be a complaint of pain. Oftentimes they won't complain of pain. They may demonstrate loss of motion or swelling of the affected shoulder or elbow. And importantly, they may simply be demonstrating altered mechanics or loss of accuracy or velocity. If they all of a sudden become a different athlete and you know they're not themselves, that in fact may be the first indication that something is wrong. And this was an interesting resource I thought I would mention. It's very easily implemented, and it can help athletes and parents try to predict their risk of injury moving forward. There are basically 6 simple questions, and some of them seem quite benign, and I'm sure most of us would answer yes on behalf of our child. And some of them are more intuitive. So, are you in the starting lineup? Do you participate in training 7 days a week? Do you participate in team practice 4 days a week or more? Have you experienced shoulder or elbow pain while throwing in the preceding 12 months? Have you experienced shoulder or elbow injury at any point requiring medical treatment? Does your arm often feel fatigued while playing baseball? If you ask these questions of your child and they answer in the affirmative for 3 or more of them, their injury risk immediately increases to 33%. If you answer yes only for 2 or less, then your injury risk is only 5%, and onward and upward you go. But if your injury risk is 33% before even taking the field that day, it may be a reason to take a step back, incorporate some of the preventive strategies we've talked about today, seek assistance from coaches and pitching coaches and trainers, or in fact seek evaluation by an orthopedic surgeon or physical therapist and start to identify and treat risk factors to begin to chip away at this injury risk so that you stay on the field and injury-free. There are some additional resources that are excellent for parents and athletes interested in injury prevention. Stop Sports Injuries is a multidisciplinary group that includes the AOSSM, and their sole mission is preventing overuse injury in young athletes, beneficial for baseball and all sports across the board. LittleLeague.org has a ton of information about some of the game management we've talked about today, and PitchSmart from Major League Baseball also has some helpful information. Our own ONS Foundation has some very helpful home exercise and rehab programs, not just for baseball, but other overhead sports as well. So thank you very much for taking just a little bit of time to talk about this important topic. I hope you all stay safe and sound, and I look forward to seeing you for the next ONS webinar. Take care.